during general surgery. At that time, there were also those who retained the strange vein bow. This was a long time ago. The plan was to drag it up from outside the strange vein bow. Really stuck. How, sorry. Experts in the group bullet comment area asked, "Can you tell me how to clear the right recurrent laryngeal poroneural lymph node? It's the trick." Tips for right recurrent laryngeal nerve dissection of lymph nodes. The lymph node of the right laryngeal reflux is doing the first step. As it frees the back wall of the esophagus, try to open the one on the right as much as possible. Then it's time to swim between the anterior wall of the esophagus and the trachea. It can be swept all the way to the opposite side. Then turn the whole trachea up. The left subclavian artery. Along the left subclavian artery, then slowly expose that. The right recurrent laryngeal nerve can be exposed. There is a clip in the video of the one involving the right laryngeal gyrus. Can you transfer to that place? In the back. At the end of the free neck free. Before or after? After. Before the ministry. A little ahead of here. Right here. You can see the right recurrent laryngeal nerve. It's the subclavian artery. It's usually in the trachea. The trachea was picked up. He can't see me on my side. You can see the entire right recurrent laryngeal nerve. It's actually on the right edge of the trachea. Then be careful when you get picked up again. The recurrent laryngeal nerve was also provoked at that time. That's a bit fast. I'll change it to the original speed. Yeah, and then go back. Same thing. Generally speaking, lymph nodes around the esophagus were cleared. They stick to the wall of the esophagus. In fact, after the back wall is open, it goes through the anterior wall to free the trachea. It is usually easy to find the left subclavian artery first. When you can find your subclavian artery, after finding it, the right throat will be easily exposed. Some obese patients. It's easy to have these little branches of blood vessels to watch out for. Otherwise, once he bleeds, it will easily affect his vision. Relatively troublesome. That's usually in the trachea. Because the windpipe has been picked up, it's on the edge of the trachea to free it layer by layer. Then the right recurrent laryngeal nerve was exposed. Just pick it up like this. I see the position of the subclavian artery below. This position will take a while because its anatomy is different from normal. Then you are especially near the corner. Ligature shoulder position. Be careful near the front angle. It's got a corner, right from here. It came up from here. So the location has to be careful. You have to peel it off layer by layer. Don't be in a hurry, just clip the whole thing directly. Sometimes the nerve is broken accidentally. Director Chio's bullet comment area has experts asking. Trapezoidal anastomosis seems to have a heavier reflux. Is this the case? How is the reflux situation? Now that the tubular stomach is done, it will be relatively better to have reflux. Of course, the patient's living habits still need to be changed. Let him sleep on his back as much as possible. Then I see that Professor Wu Yuan has considered it. Free the mucosal layer a little longer. Then put it after the mucosal layer is anastomosed. Spread the whole thing into the tubular stomach. Then do the grassroots. It can actually be. Rely on some matching methods. Alleviate his reflux symptoms. Second, he still needs to pay attention to his eating habits. This device fits. Indeed, there is still reflux. But when it's done, the amount of reflux will be relatively small. Observe trapezoidal anastomosis. Does not weigh the tube position. Is it the same as normal tube positions? It will still be a little thinner. Almost will be a little thinner. How much is 3 cm like this now? 3 centimeters, 3 or 4 centimeters. Director Lee has an expert asking. The lower esophagus, near the cardia, where is the detachment site? Just lower. Still near the stomach. From this is in the stomach. Kind of hit the bottom of the stomach like Ivor Lewis. Broken from the bottom of the stomach. In principle, try not to bring the mass to the abdominal cavity. Right there in the original location. Just drag it out of the mediastinum by the neck. After all, try not to put the lump. Put it in the abdominal cavity for surgery. Otherwise it won't feel good. If you break too high, the lump is coming into the abdominal cavity. One more problem in the bullet comment section. What thread is used for the pull rod thread? This is okay. Outside or inside of the protective case? The current purse line. Purse thread needle from the inside. Just poke it out from the left and right. Just take out the needle about under the rib edge. The one pulled by the free esophagus in the mediastinum. What is the name of the sheath instrument? Pusher. Normal pusher. Knotted. Not a bezel. It's the plate-like one. Yes, there is actually one. Actually used. Because I didn't buy that specifically. It's actually built on something called the mediastinal exposer. It also has a traction in it. It's actually on the market now. Because of the medical insurance problem now, many things are not easy to buy. What if you had a mediastinal exposer? In front of it is a flat. It's actually very similar to the pusher. So now I use this usual pusher. The second half of it must be round. If you are flat, you will leak air. So I chose this one. About 1/3 in front. It's probably a flat one in front of it. In fact, it's just a regular pusher. Then it just happened. After 2/3 it is round. In this case, it is not easy to leak air. It's actually just a pusher. Just a thicker pusher. Like this. It can be made into a line. It's just an anterior mediastinal leak. Just exposed. The video happens to be that one. It's a needle. Just sew it out with a purse needle and thread. That's about that big. This purse pin goes along that rib arch. The approximate position of the lateral edge of the rectus abdominis. Then near the rib arch, go out to the sides. Fix the thread to the position of the esophageal hiatus. Then after lifting like this, in fact, it mainly exposes the left lobe of the liver. After lifting the left lobe of the liver, it's just the whole field of vision below it. Director Chiu, where do you think the main difficulty of the surgery will be? Now I feel like this free. In fact, I think the left and right throats are back. In particular, lymph node dissection of the left odd vein arch is a relatively difficult position. put the so-called and connective tissue that keeps it close to the esophagus. You've got to cut it off on this side of the esophagus, then lean against the esophagus. Because I make a single hole through the neck, the space is relatively small. So basically there are only two people holding the mirror and the main knife. No third person is doing it. So at every step of the way, you have to think about it. That's usually just a revealing device. Then the other pair of Maryland pliers. So when the lymph nodes are freed, try to attach the connective tissue to the esophagus. Then when pushing the esophagus, it acts as a lift. TPL lymph nodes can also be removed. Actually, I think it's more difficult. The crescendo is difficult to clean in this mediastinum. Originally, it was also when it first started to clear. I'm not particularly satisfied yet. So location. I've been trying to figure it out. Now the main two sides. Especially when it strays to the left side of the esophagus. You can open the main bronchial position of the esophagus first. A little easier. So it's like putting the left and right bronchi on both sides. The lymph on the other side opens. And finally, there's this bulge. What's the benefit of this? If the free bulge tip seeps, not a lot. Since the position of the bulge and tip, because Maryland pliers are straight, there is no way to turn. So the cleaning of that location to be further optimized. Or there are new bendable instruments that come out that can solve it. There is another one for Professor Hu Yan. He cleans through the abdomen. The abdominal cleaning also has his disadvantages. One is he's going to make 5 holes to be made, and then the blade sweeps. He has a lot of pressure on the heart. He said that after one press, his heart rate's coming down. Think it's a problem. Now there is another one. Professor Jiang Bo. He has one on his side in the second rib. Second and third intercostal. That one is probably near the bulge and the chest is lifted up. That's one way. It pulls apart the fabric of space. Then add another auxiliary hole. It's going to be easier. Because everyone is still in the exploratory stage. So, let's work together. The second and third ribs are lifted up. Is it like doing the subsified mediastinum? Exactly. Kind of like that sort mediastinum. Equals your exposure to the heart. Because behind the heart, the whole heart is still pressing down more severely to be exposed. For example, after you do a neck-free Jingfu again, it is to add force on both sides at the same time, which is also a way. About the incision position. Will the neck and shoulders be raised? A neck pad is a thin little pillow. The head is in a position similar to the thyroid. Then the head should turn to the right. Then do the abdominal cavity and raise the upper body by about 30 degrees. Then lie 30 degrees on the right side. So he let his whole stomach sag naturally. Exposure to the stomach at that time. The stomach is basically rarely gone before and after. Let it sag naturally by the action of gravity. By gravity. Tilt 30 degrees to the patient's right. Yes. One is to raise the upper body 30 degrees. Then lie on your right side 30 degrees. I mentioned the posterior sternal path. Wim. Did you dissect it from behind the sternum? Generally, there are fewer double single holes through the sternum. The posterior sternum is usually because I have done sternum after a period of time before. The probability of leakage seems to be higher. Therefore, it is generally targeted at some patients with foreign invasion. Or there are some patients who need radiation after surgery. There are cases of retrosternal surgery. If the sternum leaks, will it be easier to deal with? Complications are milder. Because of the words behind his sternum. This complication in his chest would be much better because he doesn't have a tubular stomach in his chest and there's no tubular gastrotracheal leakage. But it has a higher incidence of anastomotic leakage than usual. Higher than the previous regular one. What's the approximate incidence? Behind the sternum. That Japanese guy is 100% sternum. That's why Professor Wang spoke very well. Behind the sternum he doesn't leak easily into the chest cavity. It's all leaking in the neck. Then he misses about 3% in normal words. The probability of a statistical omission in the past 2 years is about 3%. 5% behind the sternum will be like this. Already high. 350 cases a year, 20 cases at 5%. Because one takes 20 or 30 days to get better. Every month, 2 people lie there. They will scold us. So after doing it for 2 years, I didn't dare to do that. Director Chiu also spoke. If you think zero cannot be removed, if you want radiotherapy later, you must do retrosternal. Usually. If you do the mediastinum, 36 cm tubular stomach behind the sternum, I have measured that size. Because his liver is blocked there, now it's actually easy to do behind the chest. I ask you, right under that endoscope, the kind that Director Liu talked about through the Zifwat process. It will be divided soon. It's easy to do. But the Japanese are 100% after the sternum. The sternum needs to be 3 cm more than the esophageal bed. Right. Tubular stomach made a little finer. Then the place at the corner of the stomach. Just give it one more shot. Director Lee, how is the drainage after you are done? Just put a number 16 old-fashioned drain in the neck. Abdominal, no, nothing else. This drain is placed on the neck as usual. It doesn't need to be placed in the mediastinum. No need to go into the mediastinum. Right. Because this kind of stomach necrosis is rarely encountered. Then he basically prevents leakage from the neck. Prevent leakage. It actually leaked the pipe that was put there. It's not much use putting it over there. If you miss it, you will go down in the future into mediastingitis or something. These are basically never found. Instead, do the mediastinum and 1 or 2 patients have mediastinitis. Leak inside. The lump is very large. That's a lot of room. Sometimes it leaks into the mediastinum. Then the others do double single holes. The leak to the mediastinum hasn't appeared yet. The incidence of esophagus in southern Fujian is relatively high. Then so his example. About a few big ones. The one with a lot of hospital cases. That's a lot. The incidence of esophagus in Zhejiang province is very low. Zhejiang is dominated by colorectal cancer. Basically surgery for colorectal cancer. Lung cancer in thoracic surgery. Colorectal cancer patients are also many, right? I used to go to graduate school in Zhejiang a long time ago. Right. Just talking about it online Fate. A long time ago, the incidence of lung disease in Zhejiang was relatively high. I don't know if it's a high incidence or what. It's a lot of surgery anyway. Right. And then it's all lung cancer. Same thing. Now it's esophagus, now it's 350. But lung cancer is 9 times the total is 3,500. The esophagus is only 1/10. Director Lee has a question. For the majority of beginners, what basic skills do you need to master can help shorten the learning curve of double single-hole surgery? Yeah, I mentioned that a little bit. The first one said, pay attention to the details just mentioned. Great attention to detail, including what Director Chiu just said. The opening should be small so as not to leak air. Then the second one said what he just said. Select the appropriate equipment. Then think slowly. The third one was also mentioned by Director Liu just now. Be familiar with anatomy. Treat reconstruction. In fact, you have to imagine it as the abdominal cavity has retroperitoneal organs and preperitoneal organs. The esophagus is actually a retropleural organ. In front of it are the lungs. Then you imagine it as it's like a ureter, or what kind of kidney? Retroperitoneal organ. Then gradually familiarize yourself with anatomy conceptually. I think my studies should be improved soon. It's going to go beyond the curve. The third one was about the instrumental improvements. So for example, you start with 10mm mirrors. Then just start being patient a little bit. Soon, we will do that up and down together. Or less of the upper mediastinum. Do a little more abdominal and build confidence at first. If you really can't move in the middle, you can go over and do that mediastinum, it's all ripped through. The original transmediastinal mirror. In fact, this surgery, it should have been first named by a German. It should be called transurethral surgery. Transhiatus surgery. It's not transmediastinal. It should be a transurethral surgery. It's just laparoscopic assisted transurethral surgery. Transparent hole surgery was first performed by a German. The first mediastinal mirror. And then around the late 70s. In the early 1980s, there was a guy named Mark. Poke it with your hands below. Poke it with your hand. Just give him the test tube and take it out. Test tube. And I remember there's a record of that. It was criticized by others at odds in the United States. Later, the surgery gradually disappeared. He's trying again. Professor Fujiwara picked up the transurethral hole surgery again. Then it was spread to our country through Professor Chao Qingdong. I think what I just said, he had an alternative surgery at some point. About 15%. Under certain indications, you still need to learn, but this idea says. Professor Liu spoke very well. Different anatomical approaches, different anatomical directions. Just get familiar with it a little bit. His real danger is what he just said. Odd vein arch and bronchial artery. You just have to avoid it. Then if you really don't do it, if there's no way to communicate up and down, just pull it out for him. Early stage esophageal cancer is also increasing, right? The early ones are also very suitable for doing, and yes to the 90s. The elderly, he doesn't go through the chest. Without a chest, he recovered quickly and is fine. Surgery still has some vitality. The abdominal dissection is so beautiful. Did Professor Wang mention anything difficult? I don't think it's difficult to have a single hole in the abdomen. You can start doing it tomorrow. I think the single hole in the abdomen is much easier than the 5 holes. And don't spread your legs. Very popular with nurses. Professor Lee has summed it up very well. Well exposed. The mediastinum can be seen before and after. I think the perspective is good. It's like a single pore for a lung. I used to do 3-hole radical lung cancer surgery. Right. Since the single hole was made, can't go back. Vision is used to. It is 3-hole in itself. You're absolutely right. Now if you let it make 5 holes, it won't work. Because his pancreas keeps hitting that place. I'm used to it. It's really like this. The same thing. I should have mentioned this one too. Its artery walls are very thick. Burn whatever you want. And just these two blood vessels. Pulmonary artery. If there is any damage, it will definitely bleed profusely. It's okay. In the only case, the splenic artery was burned. But soon you grab it and you're fine. Then make a small opening and that's it. So there's no risk. Then it saves a lot of time. Then the turnaround opens very quickly. Right. The turnaround is very fast. It's already open, don't use the spreader. So that's great. You can also have a hiatal hernia. Very, very good. In a few minutes. Then away from that hole. There was a hole in itself just now. Don't go to that seam. Just sew the hole twice. Sew it with a knotted thread. Just fold the stomach casually. Hiatal hernia has also done a lot. Many patients woke up the next day. They were all discharged the next day and the third day. That test tube level 3 is fine. Broadening the indications for surgery. Now hiatal hernias are all done by gastrointestinal surgery. And it turned out that what they did was pretty complicated. Surgery is rare. They are trying to broaden their game. And then we have lung cancer because we have so many cases hanging in there. So I didn't care so much. Exactly. Teacher Lu has basically been almost an hour and a half. Excuse me, it doesn't matter. You summarize. I've been talking a lot. No, you speak it very well. Teacher Lu summarized. Director Lee, please summarize. So I'll just say a few words. The first one must learn surgery. The second indication. That's like what Professor Lu said just now. It can be obtained from some, for example, ESD fails. Or start doing it very early. Be sure to do a PET before doing it. Strictly grasp the indications for adaptive surgery. Then do a treat reconstruction. Familiarize yourself with anatomy. Then choose the appropriate equipment. Then think more broadly. Be patient and do it slowly. I think it's a simple surgery. This is mediastinal. But in terms of mutual single holes, I think it's very simple. You all saw it today. It's the same as a single pore lung. And it's simpler. So I think we will do a single hole together starting tomorrow. Is it okay to start with single port laparoscopy? Thank you Director Lee and that Professor Wang. Thank you Director Lee for your excellent explanation. I'm sure there will be many new questions in the comments section or live replay. You can leave a message under the comment area. You can also put the theme of the live broadcast below. Thank you for watching and asking questions. After the time of the next live broadcast is confirmed, it will be VATS official account and group notification of Extrathoracic Surgery Network. Stay tuned. See you next time. Director Miao asked when the class would start. He's going to check it out. I want to learn from Director Miao. Director Miao wants to get together. I will also visit you when I have the opportunity. I'm here to learn from you. That Director Yi is really a sharp swordsman. Director Yi is going to visit Director Ye's surgery. Okay. Thank you Director Lee. Thank you Director Wang Ming. Thanks. Good chance to meet again offline. Okay, goodbye.